I just wanted to reset the clock so that we start lecture and then you don't have to listen to, a bunch of dead time. So it's just a click on and off for that. So we're in week 7. We only have one more exam and a HESI left, only one more quiz due. And then you're going to say, so when is the quiz? When you look at your syllabus, it shows it next week. Next week is Memorial Day. Memorial Day, there is no class. So when are we doing that quiz? We'll be doing that on week 9, and it will cover week 8 information. Now, because you all are not here next week, I will post a recording and I will post everything you need with all the stuff I'm doing tonight so that you have it there in your pile of stuff that whenever you have a chance, you can listen to the recording. GIGU, which is week 8, is a lot of information. A lot of it's memorization. I'm handing out another matching sheet, just like the respiratory cardiac one. I'll be sending that one out for you also, so that you have what are those key names of these things. And let me tell you, you'd be surprised how much stuff in GIGU that you've never heard of before. I'm always amazed when I go down the list. It just keeps going and going and going. So that's next week. So no class next week. You're responsible to listen to the recording and know that you will have a quiz on that the following week. And I've already loaded it. I already know it's there and ready to go for you on GIGU. So this week, we just have a discussion question and you have a CJ Sims that are due. Anybody who wants to meet with me regarding this exam, please make a message. Let me know. The ranges went from 70 to 96, and that's before any changes. That's not bad at all from a start point. So I'm going to try to get your grades out by Friday afternoon. I know that's your biggest thing. There's only one more class left on Friday, so I try to catch it right after that class. So Friday evening, I'm going to try to get your grades posted because I know that's a sense of big stress from you, wondering what was my grade, what was my grade. Okay, nobody did horrible on it. Okay, so take that, get it, throw that away. Most of you did pretty decent on it. So this week we have a lot of stuff. We have endocrine and we have some cerebral dysfunction. And I'm going to teach it to you on a Cahoots. Now, you do have the PowerPoint. I have loaded up for you, but I think those key concepts that you need to understand are in the Cahoots. And I'm going to show you how to read the words and how to understand what they mean, okay? Because sometimes it's just listening to the words, you can figure out something and never heard of it before. So let's go ahead and do that. So week 7 endocrine, we're going to be talking about diabetes. We're going to talk about thyroid problems, adrenal problems, pituitary problems. So how do you keep it all straight? Especially endocrine, it's a lot of things. Um, just know that there's different areas in the body that do affect the endocrine system, not hormones of some sort. We have a pituitary gland, we have a thyroid gland, we have a parathyroid gland, we have adrenal glands. And a lot of those are, a product of something there. So if we can keep track what comes from where, we'll be okay. So I'm going to try to help you remember those things. All right, let's get going. Cerebral or endocrine dysfunction. Growth hormone is administered by what root? Now, sometimes children are born to a family of normal height, because that's the first thing I'm going to ask. How tall is the rest of your family before I think you're short, right? This is something just like diabetes, and it's going to really take that adherence in order to grow. What they say about growth hormones, it's subcutaneous, just like insulin. So it takes a lot of commitment by the family, right? And it's every day. And we measure it by how much do they grow. They say once you stop growing an inch a year or less, that they stop it. And again, you're not going to make a short person grow if the familiar genes are not taller than where you're starting at. So again, great question. What is the rest of your family? Are they tall or are they short? Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. And you're like, oh my goodness, what to do with this? Let's take this word apart. Antidiuretic, against urinating hormone, a syndrome. So if you're not urinating, what are you watching here? It's all about intake and output. SIADH. So this is the pituitary gland. We have stuff that diabetes insipidus, which you urinate too much, you drink too much. And then the other side of the pituitary gland in the anterior lobe is this antidiuretic hormone. And this stops you from urinating. So too much of either can cause too much urine or too little. How do we measure its intake, output, and daily weights? Daily weights are always important too. We can see any weight gain. Which of the following are signs of syndrome of an inappropriate antidiuretic hormone? So, antidiuretic against urinating hormone, what would you see? And that's how you have to think of these things. Pull out a word. What do you know? What can you make sense of? So if you're not urinating, you're going to have a decreased urinary output. What we might see? You might see an increase in daily weights because you're not urinating, right? You might see any swelling, peripheral edema, even congestive heart failure type edema. All of these things can occur with this. What is important to cover when teaching the family about polythiazole? This is also called PTU. It's a medication given for hyperthyroidism, which means too much thyroid hormones being delivered. So this medicine blocks the amount of hormone that comes out. One of the side effects is leukopenia. Basically, you get immunosuppressed or your white blood cell count goes down. Leukopenia, decreased white blood cells. So you don't have white blood cells, you're going to be more at risk for infection. So you're at risk for fever, sore throat. So any patient on this medication who gets sick needs to tell the doctor it might be medication or it might be a real illness. Okay. A multi. An initial sign of diabetes insipidus. This is opposite of the syndrome of inappropriate antidiuretic hormone. Again, it is the posterior lobe of the pituitary gland. And this secretes a hormone. And it's all about fluid. Diabetes insipidus has nothing to do with the blood sugar. It has only fluid, which means I'm thirsty and I urinate. Okay. Polyphagia, or I'm hungry, is diabetes mellitus. And let me explain why you're hungry. In diabetes mellitus, your body cannot take sugar and use it. So the sugar just builds up in the body, but it's not used. So your body's hungry. So it wants to eat. And that's why you're polyphagia. You're hungry, but your body can't use it. So you keep eating and eating, but still you're hungry because the sugar is just free floating in your body. Okay. So that's only diabetes mellitus. Diabetes insipidus is only fluid. I'm thirsty, drink, 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 urinate, urinate, urinate. They actually say in infants, a infant that we are suspecting diabetes insipidus, you can give them all the bottles of milk formula that they want, right? But if you give them a bottle of a water, their thirst is satisfied. So that's one way that you start to figure out infants with diabetes insipidus. Another multi. What are the clinical manifestations of juvenile hypothyroidism? Well, with hypothyroidism, it's the same as adults as it is in children. The only difference that you see in the children's variety has to do with growth. That is the biggest difference. You need all the proper hormones in order to grow the proper way. With hypothyroidism, they're going to be stunted. You're going to have a decreased growth. But just like adults, dry skin, sparse hair, might be a weight gain with hypothyroidism. I know many people say, yeah, my thyroid level's low. That's why I'm a little bit pudgy. So it's not lost. Constipation, cold intolerance. And then in children, it's the growth. That's the difference. A child had a simple febrile seizure. What education would you provide the parents? Now, febrile seizures is common and it can occur in young children, ages 6 months to 6 years. Usually they grow out of febrile seizures, thank goodness. But if you have a child who's apt to having febrile seizures, what do we need to teach that parent? Well, we need to how to keep that child safe during that seizure, right? Because remember, if they're seizing, they're foaming at the mouth, right? Maybe they're even incontinent, maybe they're tonic-clonic movements. If there's something in the bed, children love to put everything in their hospital bed. And when they're moving, they can scratch and they can hurt themselves. Side rails are banging on them. So, safety. They're going to vomit, most of them. Turn them on their side. If they vomit, have suction available, not to stick in their mouth, nothing in their mouth, but to clear the area so they're not inhaling the vomit they just vomited. Safety, 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 very important when we talk about seizures. Febrile, tonic-clonic, doesn't matter. Seizures, we treat all the same, all about safety. What type of seizure is when the body's jerking, foaming at the mouth, and the child is rendered unconscious? We used to call these grand mal years ago. Today, they're called tonic-clonic. It means arms and legs both go. What notable sign may indicate increased intracranial pressure in an infant? Well, an infant can't tell you their head hurts or they have a headache, but they can show you some things. So infants, one of the things that they'll show you is you can walk into a nursery full of a bunch of infants and they're crying. You can tell the one child who has some sort of neurological problem. It's their octave is a little bit higher. It's almost like you nails on a chalkboard. You can hear the difference in their cry. It's a high-pitched cry. You might even see like their veins and their scalp veins are protruding when you start to see that. But the cry is always the clue. And increased intracranial pressure is going to be a fontanelle, whether they're asleep, whether they're crying, is always going to be, bulging, not only when they're crying. Most infants will bulge if they're crying. Normal, healthy brain still will, when they're crying. All of the following increased intracranial pressure except. So why do we need to know what increases intracranial pressure? And if you have a child that's come in or an adult who's had some sort of brain injury and that's your concern, you have to take care of them. So whatever care, whatever touch you do to these children or adults, it's going to increase pressure. Of course, fluid you always are concerned about. You don't want any extra fluid because they'll just increase the pressure in their brain. Coughing, suctioning, all of those things. But heart rate does not affect it at all. Respiratory rate does not affect it. It's that stimulation, that outside. So, yes, we still have to suction an endotracheal tube, but it won't be aggressive. It'll be in and out, making sure you have a open airway. What findings can alert you to a head injury getting worse? I mean, I equate this to those children who come in who slid into third base and they hit the defendant's knee and they were knocked out. And the one thing I would hear repeatedly is, so was I safe? Did I win the game? Did we win the game? Is daddy coming? Was I safe? And repeated, repeated. And if the head injury is getting even more worse, they're getting to the point where now where they're not even alert and not able to talk, okay? But it starts with that confusion, that change of orientation. Multi. What does it mean when you see a fixed and dilated pupil after a head injury? You know, one of the things that you will see if you've ever worked in an emergency room, you get a child or adult in who's been in an accident with some sort of head injury. First thing we look at is their pupils. Are they still reactive? If they're still reactive, we know there's still good brain waves going on there. When we see it fixed and dilated, it's telling me there's big swelling going on and probably a brain stem injury. Now, the brainstem is the major, brain of the body. It does heart rate, does respiratory rate, temperature, everything. And if we are a fixed dilated pupil, it is suffocating and smothering that area. And it's going to cause, a complete loss of their consciousness and, become in a vegetative state if we cannot relieve that pressure quick. I mean, they say 5 minutes, but as quick as we see pupils going, one doesn't react like the other. I mean, we're looking at that pressure and we need to release it. Needs to go to the surgery, get it removed. Medication may be used for a child with cerebral edema due to a fall. So we're talking about edema, swelling, fluid, but we're talking about it in the brain. And there's a difference between congestive heart failure or having peripheral edema than there is in the brain. And there's two types of diuretics that we do use. When we talk about the brain, it's all about mannitol, all about mannitol. It's used for brain, increased pressure. It's used for kidney failure. It's used for toxic things, but it's perfect for the brain. You give it and you'll see a bunch of fluid come out right after. Furosemide Lasix does not work that well on the brain. I mean, that's almost for everything else, but not for the brain. That's mannitol. Febrile seizures usually occur in my first grandson had one febrile seizure about at 18 months. And then mom carried around a thermometer, ibuprofen, and acetaminophen wherever she went all the time and never had it again. I mean, he's now 12, so they're gone. But they're very, very, very scary. The good thing about it, and parents will say, does this mean now my child has epilepsy? Does this mean it's always going to happen? And that's probably the first question. Oh my God, my kid's going to be having seizures for life. No, it doesn't mean that. Most of the time, they grow out of them. And the only thing that we need to teach is them to be aware of the temperature. It's a temperature that was normal, and 20 minutes later, now it's gone from 98 to 102. It's the rate of rise so quick that sparks the brain and going into a seizure. So teaching that parent, to be aware of fevers, getting that ibuprofen or that acetaminophen in quickly. And then, of course, it's all the safety stuff, keeping the child safe in case they do have a seizure. Childhood hypopituitarism results in which condition? So there's two sides of the pituitary gland. The posterior lobe is all about fluid. The anterior side's all about growth. So fluid growth, hypopituitarism is growth. What's one here that looks at growth? That's low, hypo. It is the pituitary dwarfism. Hyperpituitarism is gigantism. How would you describe precocious puberty? I mention this because it can happen to some children. If it happens too early, we can give medications. The name's actually called Lupron, and it is another injection, sub-Q, that we give, and it basically stops you from going through puberty quick. If you can imagine being 6 years old and getting breasts or getting, your menses, or man getting beards, and, the testicular enlargement and whatnot, a 6-year-old is going to be really teased. You want them to hold off to the normal time, 10, 12, what the normal time is. A multi. What lab values are important to monitor with a child with congenital hypothyroidism? What do we worry about with hypothyroidism? Hypo is lack of thyroid hormone. What do we worry about most of all with children, and how do we monitor that? Well, we look at the thyroid levels, T3, T4, TSH. That's only hypothyroid. Growth hormones is the pituitary gland. Cortisol is adrenal gland. You need to remember those things. If you can remember that, you're halfway done with remembering what you have to know for these concepts in these sort of hormones. Can you monitor a child with hypo or hyperthyroidism? How do you know if they're hyper or they're hypo, or if they're getting medication for hyper, if it works? How do you know? All about growth, right? It's all about height and weight and monitoring it. I mentioned in the very beginning, the one thing we do to children every visit, whether ER or a regular visit, every child is weighed. Adults were never weighed. I've been lying for years how much I weigh because nobody's ever put me on a scale. Children are put on a scale because we're looking at something like hormone, whether it be growth hormones or thyroid hormones. We're making sure that child is where they're supposed to be in growth. What acid-base alteration would you see in a diabetic child with Kussmaul respiration? Well, what is Kussmaul respiration? So respirations that we see when you're in diabetic ketoacidosis. The body is really cool. It knows tricks that it can do to try to help when the body's not doing the right thing. So with diabetic ketoacidosis, the body can't get rid of sugar. It starts to eat proteins and fats, and ketones are made. And those ketones create an acid problem in the body. It goes into metabolic acidosis. But the body's hungry, so it keeps eating these proteins, it keeps eating these fats. So the glucose in these children, I've seen 1100, and I've also seen the lowest ABG number I saw was 6.89, and the child made it. Again, these Kussmaul respirations are trying to make an alkalotic situation. So these slow blowing off type of respirations create a respiratory alkalosis, which tries to compensate for the metabolic acidosis of diabetic ketoacidosis. Okay, it's the opposite, trying to help it. Body's trying to help itself. A multi. What would a child with Cushing syndrome look like? Well, Cushing syndrome has something to do with cortisol, and it has a lot to do with prednisone. And this is all about adrenal gland. In Cushing syndrome, this would be a child or an adult because actually they threw me into Cushing syndrome at one point in my life. It's too much steroids for too long of a time, and the body can't handle it. So what happens? You gain weight. I mean, you're not eating, but you're gaining weight like crazy. Your face gets big and round. You get little hairs on your chinny chins. You get acne. Your cheeks become red. They call it ruddy, but it's like this big red cheeks, um you've just ran the mile. Now your cheeks are red looking thing. Okay. And then, of course, you have skinny arms and legs, but you get all this fat on your face, your neck, and your trunk. And that's Cushing syndrome. This is due to too much steroids. How do you reverse Cushing syndrome? Well, if it's due to too much steroids, you taper them off very, very slowly, and it can be reversed. A multi. You walk into a room with a child with a fever of 104.6 and they're having a seizure. What are you going to do? You walk into a room, they got a fever, 104.6. They're having a seizure. What do we know about seizures? What's our responsibility? Again, seizure, my responsibility as a nurse is safety, safety, safety. Look inside the bed. Are there toys? They have toys and they have pencils and crayons and pens and trucks and, all this stuff. And they have sharp edges. If I walk into a room, they're having a seizure, I'm going to take it and put it down at the head of the bed, put it on the floor, get rid of it. And it's the end, so nobody's going to step on it. Side rails up. I'm going to throw blankets over them, pillows over them. I'm going to put the bed flat. Turn that child up on the side. If they vomit, then I can have suction there just to clean the area so that they're not suctioning that in. Okay. So, again, all about safety, 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 and keeping the airway open. Just turn them, nothing in the mouth. An autoimmune disease of the thyroid gland. This is usually your young adolescent girls, late school age, young adolescent girls that we usually see this occurring. The thing with autoimmune thyroid gland is this is something that you can't remove. It's autoimmune, it has to stay there. So, what is the treatment of this? Well, it's multiple sorts of thyroid medications. Again, it's an autoimmune disease. It's usually girls. Surgery's not what you do, it's only regulating it through medications. And then, of course, making sure that all the medications are within the levels they should be. Addison disease. It's an adrenal disease. It's not Cushing's, it's Addison's. I mean, adrenal gland itself produces cortisol and aldosterone. When a child is born that has Addison disease, they don't have enough cortisol, they don't have enough aldosterone. These children end up with ambiguous sex characteristics. They could have a penis and a vagina, or they could have testicles and a vagina. I mean, they can have all different parts. And that's part of Addison's disease. Now, if you're born with Addison disease, not just the problem with, assigning a sex to this child, it's also maintenance. This child will be on cortisol and aldosterone for life. And again, periods of stress, etc., they're going to need extra doses. And we'll just give like an extra dose of steroids at that time. I won't die. A ventricular peritoneal shunt. This is some of the cerebral. Now, we've talked about hydrocephalus, we talked about that fontanelle, and we talked about it getting extra fluid in there. Well, it needs to be removed or it's going to swell and it's going to, have the brain die and all of the major functions because of the pressure. So, this is a tube that the neurosurgeon puts up into the fourth ventricle. The tube comes out behind the ear, and there's like a little bulb there. Do not touch it. Do not pump it. Now, neurosurgery can, but we leave it alone, okay? And it comes down in front of the chest into the peritoneal cavity. What is our job? Well, we want to make sure it works. How do we know? Well, we're going to measure head circumference and abdominal circumference, making sure that's not getting big, right? And know that this is for hydrocephalus. A common sign of Graves' disease includes blank or protrusion of the eyes. They have a new commercial out about eye drops for this. The lady comes out in sunglasses. Have anybody seen that commercial? From one good sign, and she'll take it off, there'll be another pair of sunglasses on. But it's exophthalmos. It's the eyeballs get big and stick out of the head. It's one of the things that they go, oh, have you had your thyroid level checked? It's one of those things that are very specific to hyperthyroidism. There are eye drops and stuff that we can give it now. I won't die. Hypoparathyroidism has the symptoms of technic muscle contractions and blank. Well, what does the parathyroid gland do? Parathyroid gland monitors calcium in the body. What does the calcium do in the body? What is it responsible for? Well, if you have too much calcium, your muscles are going to be on overdrive, right? If you don't have enough, they're just going to be they just lay there because they don't have the spasm. So, muscle weakness and the muscles not working. And of course, low calcium levels. How do we treat it? Well, we make sure they have vitamin D because they're related, and also that their calcium levels are up. Die. What are signs of hyperparathyroidism? I just got a level back on myself, and I have quite an elevated parathyroid level. So I was confused about what to do for it, and I did a lot of research. And you either treat it with vitamin D or you have surgery and get it taken out. But we still have to go to the endocrine. I'll still take care of it. I'll keep you in contact. But nausea and vomiting, confusion, and paresthesia. Paresthesia because your muscles are in such spasm, you just don't even feel them that well again. Again, how do you treat it? As I said, you either give, vitamin D or it's surgery to remove it. What does the parathyroid hormone do? So the parathyroid gland is all about calcium. Remember, calcium, magnesium are both with muscle contraction. That has to do with not only your muscles moving, think about your diaphragm and your heart. I mean, these are all muscles. You need good spasms to make it work. Which of the following might be a cause of an adrenal crisis or Addisonian crisis. Adrenal gland. What do we know about adrenal glands? What is it related to? Remember, it's cortisol, it's aldosterone. Too much steroids and taken off too quickly will throw you into an Addisonian crisis. So, how do you think you treat an abrupt withdrawal from steroids and you're going into a hypertensive crisis, et cetera, et cetera? Give a steroid. You replace what's missing, and then it will stop it. And then taper it off slowly. You can't just stop it. A multi. Cardinal sign of diabetes insipidus. Remember, diabetes insipidus, posterior pituitary gland, has everything to do with fluids, right? DI, fluids. So it has everything to do with thirsty and urinating. Again, it has nothing to do with wanting to eat, polyphagia. That's diabetes mellitus. And it's an increase of urinary output. You don't even have to drink and you still keep urinating. A multi. A congenital adrenal hypoplasia parent teaching should include this is that adrenal gland. It's not giving the cortisol and aldosterone. So we're don't have the hormones we need, right? Remember, this is a child who's going to have cortisone, aldosterone replacements for life. The biggest concern is you have to have a gender assignment. They don't have all the body parts, either boy or girl. And I mean, they'll go through and look at what's on the inside, they'll do some testing, but they'll just assign what they feel it's most what it should be. These children are sterile, they'll never have children, never. Okay. What causes type 1 diabetes? And I love this. Bob has 36 candy bars, he eats 29. He now has diabetes. Basically, it's destructions of the beta cells by an autoimmune process in the pancreas. Now, let's go simple. What is diabetes? Diabetes is the body's inability to digest sugar and use it. So, body's not getting any carbohydrates, but you're still eating them. So, you have all the sugar in your body that your body can do nothing with. Now, your body's hungry because you can't use this sugar that's in there. So it starts eating fats and proteins. Because they're eating fats and proteins, a byproduct is ketones. So this is a child that would come into the emergency room. They would look pale. They would be lethargic. Most of them are either carried or wheeled in. They're so weak. Okay. The blood sugars are well over 500. As I said, I've seen 1100. And you will smell rotten peach in the air. That is the smell of the sugar. It smells like a rotten, ripe peach. It's like sickening sweet, the amount of fruity smell that comes off of them. So, how do we treat a child with diabetes? Well, if they're coming to you, their blood sugars are high. We need to dilute it immediately. We're going to be giving a bolus of normal saline. Their blood sugars are high and they don't have insulin. We'll be giving a slow, continuous IV infusion of insulin. And we'll be monitoring as that blood sugar comes down. If we do a urine test, we'll be seeing 4 plus ketones, 4 plus sugar in the urine, and that's absolutely normal. As I said, these children go into metabolic acidosis. their pHs, which should be 7.45 is normal, right? 6.9 is usually what they come in, 7.0. So these children are really confused and they're really, weak. Once we get those blood sugars down and then the pH starts coming up and then we replace all the potassium, these kids do better. But again, they're hungry, they're thirsty, they're urinating, and we have to correct that blood sugar. That's our priority, fluids and insulin. So, which statement about a pheochromocytoma is correct? This is an adrenal tumor. This is a sneaky tumor where the patient will be claiming of feeling like their heart rate goes up and massive headaches, and their blood pressure goes up and down during these times. It is a catecholamine producing tumor, which means on manipulation and whatnot, all of a sudden it squirts out like epinephrine, and heart rate goes up, blood pressure goes up. It takes a while to figure it out. People say, all right, elevated heart rate and elevated blood pressure. Oh, let's check out the heart. Well, it's the adrenal gland. It's not the heart. So it takes a while to diagnose this. And then they can remove it once they figure it out. I mean, as a nurse, we know they have it. Of course, we'll be monitoring their vital signs. A multi. What action should the nurse implement in the care of a patient with a pheochromocytoma? Remember, adrenal tumor is sympathetic type of responses, catecholamine type. I mean, it produces what epinephrine would produce if you gave, a quick shot of it. It has nothing to do with blood sugars. It has to do with heart rate and blood pressure. And it's nothing to do with weight. It only has to do, it's like giving a shot of epinephrine. What happens? Heart rate goes up, blood pressure goes up. It's nothing to do with weight and nothing to do with sugar. A multi. Nursing care of the unconscious child include you have a child who's unconscious, maybe it's a head injury, right? What do we need to monitor? Well, we know if they're unconscious, we're going to do all the neuro checks, whatever Q1, Q2, whatever the doctor's ordered. Vital signs will be done. I mean, we're be looking at what's the blood pressure, what's the heart rate. I mean, if they have a temperature, making sure that we medicate for that, keep the heart rate down, letting the body relax. Intake output for sure. We don't want to overload them with fluid. Are we going to be monitoring pain? Yes, but it's more because we're monitoring their vital signs. We see, heart rate going up, blood pressure go up. Many times they're telling us they're having pain. So yeah, we would be giving something for pain. What might you suspect if a child feels jittery, sweating, and is dizzy? What does that sound like? So that jittery, sweating, dizzy, that's all about being hypoglycemic. Did you treat a child that was jittery? The answer is depends on patient condition, doesn't it? Are they awake telling you they feel sweaty and dizzy? Or are they on the floor unconscious, sweaty and dizzy, right? Or jittery looking. So they're alert. As easy as giving them a glass of milk or orange juice could work. If they are unconscious, this would be your glucagon. And remember, when you give glucagon, they are going to vomit. Always turn them on their side. Symptoms of DKA are diabetic ketoacidosis. What do you see? So we are going to be seeing that fruity breath. We are going to have ketones in the urine. We're going to have high blood sugars, and as I said, fruity breath is that rotten, very ripe peach. All of the above that you're going to see here. A multi. An adolescent with a BMI above 95% has been urinating a lot. Test can you anticipate? What do you think they're looking for here? Remember, it doesn't have to be one thing. You got to figure of everything. What could this be? Urinating a lot. Well, do you have an infection? Number two, urinating a lot. Is that a hormone thing? Is it a diabetes thing? Is it a pituitary gland thing? Okay, these are things we'll be looking for. Simple old urinalysis. Is there infection? And of course, a hemoglobin A1C. Yes, we're also going to check the electrolytes because it could be potassium now is getting low and you could be worried about it. Pregnancy wouldn't do anything with urinating, so that would not be an answer here. Diabetic ketoacidosis is caused by what? Diabetic ketoacidosis is the body not having insulin, and you have to use something else to give the body a food it wants. So if it doesn't have insulin, it can't use sugar or carbohydrates. So it has to go to fat and protein for the other types of fuels. And the byproduct is ketones, which is ketonuria. Dying. A child is admitted with a blood sugar greater than 600 and large ketones in the urine. What is your priority? What are you going to do first here? Sickle cell priority is IV fluids and dilate those vessels. What am I going to do with diabetes? What's my priority here? I'm going to be giving IV bolus normal saline, dilute that sugar. And number two, I'm going to start them on a very slow, continuous infusion of regular insulin. And regular insulin is the only one that can be given IV. Sub-Q is not going to do anything for a child with a blood sugar like this. You need a slow, continuous infusion. A diabetic child complains of feeling jittery. The blood sugar is 45. What is the best treatment for the child? What did I tell you about children and these symptoms? It depends on the patient condition. Is this patient awake or not? They're complaining, they're telling you. So, this child complaining of feeling jittery, get him some orange juice, get him a glass of milk, get him a turkey sandwich, get him something. Very good. Your patient has experienced a head injury. What would most concern you? So you have a head injury. You're always worried about increasing pressure in the brain. What would show you increasing pressure in the brain? Well, your pituitary gland's right in there, and it's starting to squeeze it. It can show all of a sudden decreased urinary output. It's telling you there's increased pressure going on, and it could be just that urinary output being decreased that's telling you that. Di- How do you detect diabetic ketoacidosis? This is a child. Diabetic ketoacidosis means I have elevated blood sugars, which means I'm going to have elevated glucose in the urine. And because I'm eating proteins and fats, I've got ketones. So ketones, 4 plus in the urine. Are many of these children dehydrated? Yes, but it's not part of how do you detect it. A multi. What would alert you that a child's head injury is deteriorating? This is a child who's now getting more confused, harder to wake up, who's becoming restless, and then the headache is getting worse. In fact, they even say it even wake them up. If they were resting and wake them up that the headache, hurts that bad. A child's been diagnosed with bacterial meningitis. What's the nursing priority of care? What's really your priority? What do you need to do first for this child? What's the most important thing in the care of this child? It could be any of these things, right? But priority, bacterial meningitis. Let's give that antibiotic as soon as we can. Remember, many of these bacterial meningitis are, air, they have isolation because, it's in the air, right? They got to be put into these rooms. 24 hours after they take an antibiotic, we could take them off that isolation. Kids don't like to be locked up in a room by themselves. They get really frightened. They want to get up and explore the world, right? So getting that IV antibiotic, getting it started as soon as possible, and you're decreasing any possibilities of, things going on. What is the primary cause of injury associated with submersion? Drowning. Remember, I live in South Florida and I've seen a few drowning in my day. And, these children many a time come in and they're awake and alert. And then in a day or two, all of a sudden, you hear that they've been placed on a ventilator and they're not doing well. Well, what happens is their lungs get full of fluid and they have a hypoxic moment. Up to 3 days later, these children could go into respiratory distress. These children, it's because many times they've drowned, right? You find them on the bottom of the pool, you take them out, and then they're recovered. By the time rescue comes, they're running around and acting like nothing happened. The problem is up to 3 days later that you could see what happens from that drowning. And those children must be taken to the hospital and admitted to some sort of monitored area, like a telemetry, at least a minimum of that. Last question. A multi. Which CSF lab result correlates with bacterial meningitis diagnosis? When you get a child in having, the headache, all the signs and symptoms of meningitis, and you're going to do an LP. You do your lumbar puncture, and I'm going to wait. I want to know, is it bacteria or viral? Well, first of all, you're going to see it white or milky if it's bacterial. That's the white blood cells in there. But the second thing I'm looking at is bacteria love sugar, so it is low. They don't like protein, so that is elevated. That with an elevated white count, you know it is bacterial. And the next order I'm looking for is what antibiotic am I going to start giving? Sherry, good job, Sherry. Number two, Jay. Good job, Jay. And number one, drum roll, please. Ashley. Good job, Ash. And Heather and a BK. So that's the rest of today. I'll be getting this recording to you. I'm also going to be getting the stuff for next week out to you so that you have it early so you can listen to it at your own um, when you want to. Okay. I'll be sending out the matching sheet with that also. All right. Anybody who wants to meet with me, just let me know. Not a problem. I'll get with you. And I'm going to try to get those grades out by Friday evening after the last class.
Can I meet
May I
with you?
help? Sure. When do you want to meet? We've got to get the grades out first before we can think about an exam.
Before we can review?
Before we can review, yeah, because we haven't given the exam to everybody yet.
Okay, can we do Friday?
Sure.
I'll just email you.
All right. Yeah, send me a message. No problem. That would be good. Thanks. Anybody else?
I was just wanting to ask you about the project.
Yes. It's next week.
Um, I know. um, 'Cause, I was wanting to see what was still available to do it on.
You know, the list that is listed in the modules isn't everything. You can pick anything you want that's related to a childhood illness.
Could I do Downs?
Sure.
Okay.
Send me a message and I'll make sure it's written down. Just send me a message, whatever you want to do. If I see like I have 3 or 4 of them, I'll let the person know. But no, you're good. You're good with
Okay.
Downs.
All right. Thank you.
No, thank you,
Have a good
Jerry.
one.
You too. Anybody else? Thank you, guys. Have a great evening.